Thank you everyone for joining us today to a webinar, Addiction Policy Forum's webinar on evidence-based strategies for preventing opioid overdose, a conversation with CDC experts. We are so excited to have so many people tuned in today to be a part of this discussion. I'm really excited to have our panelists, our experts join us. Dr. Jennifer Carroll is an assistant professor of anthropology at North Carolina State University and an adjunct assistant professor of medicine at Brown University. And Michelle Putnam is team lead for the division's Office of Policy Planning and Partnerships at the Centers for Disease Control at CDC. Really great to have you both join us today for this discussion on evidence-based practice with how COVID and our addiction epidemic have sort of hit each other head on, and increases in overdose rates and individuals and families in crisis sort of, across the country, really. We really want to dig in and shine a light on evidence-based strategies that exist and the types of tools and activities that our communities can start employing to really change this and have an effect on the ground, and really digging into understanding better from you all on what should be on that checklist is a really important conversation. So thank you so much for joining us today, and for so many folks from our network to tune in. I thought we'd kick it first to Michelle to give us an overview. And again, thank you for all the work that you do at the CDC.
Thank you, Jess, and it's so wonderful to be here. I am going to share my screen with you all. And again, good afternoon or morning, I guess, where you are. I know we've got folks joining from across the country, but I'm really grateful to be with you all today. And looking forward to what will hopefully be an energizing discussion, especially for those of us coming on post-lunch, on ways that we can engage in reversing some of the trends that Jess was just speaking of what we're seeing related to drug overdoses across the country, especially over the past couple of years. So you all, and where you sit, are most likely all too aware of the current levels of drug overdose deaths in the US. And through your work are most likely familiar with the individuals, the families, entire communities that are behind these trend lines here. So I'm not going to belabor burden here today, but I do want to quickly check in with you on where we are as a nation. So the National Center for Health Statistics here at CDC posts monthly provisional data that you all are probably aware of, but the latest of which shows us through what's occurred through September 2021. So you can see the spike in deaths that coincided along with the pandemic, starting really in January 2020 and going through probably about mid-May or May 2021. And I think you all, of course, are very familiar with what led to that increased social distancing, so just some of the mental health impact of the pandemic, as well as drug supply kind of led to that increase. But I always check in on these numbers just because I like to envision the trend line, what it looks like in out months and out years, and just generally use it as a visualization exercise to envision those lines going down. It kind of gets me out of bed each morning. But here within the Injury Center at CDC, we support states in improving the data that we're getting. So the chart that I just showed you on the last slide was gleaned from death certificate data, but some of the data that we're getting here within the Injury Center is gleaned across a number of additional sources. So we publish on this data a lot. Again, we support individual states and jurisdictions in getting the data in real time, but we also try to post, look at it and examine it and publish it so you can see what's going on in an aggregate level. We did put out a publication a few months ago that gave us some additional data about contextual data on what leads up to a drug overdose death, potential missed opportunities, and the exact substances on board at the time of the death. And this publication looks specifically at deaths related to illicitly manufactured opioids. So here you can see the co-involvement of other substances that we're seeing contribute to some of these deaths, with, of course, fentanyl, specifically illicitly manufactured fentanyl, being the highly potent factor underlying all of these deaths. So 40% of IMF involved deaths here involve stimulants, particularly methamphetamine and cocaine. And you can see that it varies by region, which is of course very important for the work that you all are doing based on where you are. But this publication, the reason I wanted to pull it out for you is it also looked at data beyond the substances that were on board. So one of the statistics that I found incredibly, hard to digest was that 56% of decedents looked at in this data set had no pulse when first responders arrived. And so in the approximately 1/3 of deaths where potential bystanders were there and provided no response, they cited some common barriers like spatial separation. So someone was using drugs potentially in a bathroom or another room. They also cited an inability to recognize what a drug overdose looked like. And in this paper, we also looked at routes of use as well. So the data gleaned here really shows and points to harm reduction, particularly when we have a substance as potent as fentanyl and as widely available as fentanyl. We are seeing that it used to be kind of the eastern side of the country, and it's just finding its way through all regions of the drug supply. We know that harm reduction can work. That's a very important tool that we have to save lives. If you think about what could have happened with that 56% of decedents, we know that we can save lives. So the hope is that this data can inform prevention efforts on the ground. The hope is that it can inform partnerships, particularly with public safety, but also with policymakers to show them that, hey, education and harm reduction have a role here. We know we can save lives. We know that this can save people. But again, data is only one side of the story, right? So that's where we come in with our partnerships and being able to communicate this. I also wanted to pull out, I said I wouldn't belabor data, and here I am pulling out chart after chart of data, but this one to me is also very important. I wanted you all to see this chart, particularly because of the box here on the left, so the chart on the left. So in this time period from 2013 to 2020, we saw rates increase across, across everyone. It's an everyone problem. However, if you look at that box, we saw rates of opioid overdose for non-Hispanic Black Americans increase by 464% in that time period. So we know, yes, fentanyl is driving supply, it's driving overdose deaths. And again, we know it's an everybody problem. Rates are increasing everywhere. But that also means that we have to ensure that everyone is equitably accessing the harm reduction and prevention strategies that we know work. So it's one thing to have them, it's another thing to implement them, and then it's another thing to make sure that everyone is able to benefit from some of these strategies. So this line for me is a grim reminder that we have a lot more work to do just to ensure that we're equitably serving everyone at risk. So CDC, we're of course a part of the Health and Human Services agency. We work within the department's Overdose Response strategy, which is an all hands on deck response that ensures our divisions and departments are focused on these areas here. So every HHS agency is actively engaged in all of the things that you see here on the screen to reduce overdose deaths. And CDC's footprint is here. So I mentioned earlier some of the data that we're gleaning to monitor and improve the data that we are getting so that it can inform prevention efforts in local communities. We also support those states, territories, and tribes in implementing basically the strategies that you see and captured here across these 5 pillars. We continue to hone in on health systems as a way not only to increase safer prescribing, that's kind of where we started at the beginning of the epidemic, was focused on safer prescribing. But now we're really leveraging health systems and supporting providers in decreasing stigma, screening, integrating linkage to care within our health systems so that we never miss an opportunity to potentially link someone into life-saving treatment. We also partner at all levels, so state, federal, local, you name it. We partner with public safety organizations. And one of the ways that we do this that I wanted to call out for you all is a program called the Overdose Response Strategy. This is a national partnership in partnership with the ONDCP and high intensity drug trafficking areas. And we actively pair a health analyst on the ground with a drug intelligence officer so that they can leverage data sets and drive productive partnerships on the ground. They've got some really robust networks. Dr. Carroll is familiar with this effort. And through this, we've seen increased adoption of diversion, drug courts, and many of the strategies that Dr. Carroll will talk about today. We also raise public awareness, as do many of you and partners on the ground. We have public awareness campaign elements that are freely available on our website. So we work a lot with health jurisdictions to make sure they've got ads and things like that. And that's all free of use that they can use from our resources. And second, we do all of this with a focus on promoting health equity, addressing underlying factors such as adverse childhood experiences and social determinants, which I know is of interest to this group, and you all are working on that, and to drive innovation based on evidence. So the strategies that Dr. Carroll will present about were all considered innovative strategies, a few years ago when we created this guide. And so the idea is to continue that innovation and plant seeds, because you all are aware that the innovation is growing. So we want to fund things that are working, evaluate them, and then rapidly scale them. That's generally the idea. And I want to leave you with this visual before I turn it over to Dr. Carroll, because the efforts I just described are being implemented in 66 state, territorial, and local health jurisdictions. So here's where we are. I kind of told you a little about what we do, and here's kind of where the dollars are going. So we send about $300 million a year out currently through this Overdose Data to Action program. So it's our cooperative agreement with state health departments and local health departments. And if you live and work in one of these purple states, not public states, in one of these purple states, or the cities here, you'll see them. Or if you live or work in Harris County, which is where we're getting to in Texas, the strategies that you're going to hear about today are happening there. And so hopefully after today, you'll have more information about what's going on there, and you'll have some additional inroads where you can leverage some of that work. So we've got the resources, we have the strategies, and I think the most important thing that we have is you all and folks like yourselves on the ground doing the hard work and making connections and showing the promise of these interventions. And with that, I will turn it over to Dr. Carroll. Thanks so much.
Hi, everyone. Thank you so much for being here today. I have been looking at folks offering their greetings in the chat, and I'm just so excited at the wild number of people that are here and the diverse efforts and talents that are here. I see first responders, I see treatment providers, I see coaches, I see program managers. I'm so impressed. So I had to log off earlier and log back on. Screen sharing has been disabled for me. Can someone help me turn that back on, please? Thank you very much. They take really good care of us here. All right, so what I'm going to be doing, as Michelle mentioned, is doing an overview of some of the high impact overdose prevention strategies that are highlighted in a CDC document that was published in 2018. I'm going to be talking about this in terms of how to both conceptualize and fruitful ways for thinking about overdose prevention, and then walk through some of the evidence that we have and folks that are actually putting this work or this science to work on the ground in their communities. All right, so from a public health standpoint, we tend to think about prevention in this way as having three sorts of stages. Primary prevention, in terms of substance use, we would think of that as preventing the initiation of substance use, period. So primary could be initiatives at any level to eliminate risk factors or injury from a disease or a risky behavior before it occurs. But we know that a lot of people who are at risk of overdose have already gone past that primary prevention opportunity, right? We're talking about people who are actively using drugs, recreationally using drugs, people who are living with substance use disorder. And so how do we serve those folks and make sure that they come home at the end of the day? So when I give talks or give lectures to students at my university or share this with anyone else, that's always what I focus on, right? Our goal is for folks to come home at the end of the day. So the way we conceptualize that in public health is secondary prevention. So for example, that aims to prevent or reduce the severity or likelihood of harms if the risk factors continue to exist. And then tertiary aims to reduce long-term impacts. So that would, both of those things would include things like harm reduction, reducing the risk that if someone is going to use drugs that's going to result in an overdose, and reducing the risk that if someone does experience an overdose crisis, it results in death. So here's an example to walk through to think about the utility of secondary and tertiary prevention. So drunk driving injuries. In 1976 to 1985, excuse me, alcohol was involved in 55% of motor vehicle accidents in the United States. And at this time, motor vehicle accidents themselves were the leading cause of death for Americans aged 15 to 24. So many policymakers, both at the federal, state, and local levels, took action to try to reduce these sorts of injuries. And this article that is cited at the bottom right, they looked at a lot of primary prevention approaches. So that means stopping people from getting behind the wheel when they have alcohol in their system in the first place. Excuse me. The most common strategies that were adopted at the state level were things like preliminary breath tests, sobriety checks, so literally setting up a checkpoint on the road and testing everyone that comes through, and also implementing mandatory jail time if someone was caught driving while intoxicated. So after a large multi-state study of all of these deterrent strategies, they found no measurable impact on motor vehicle accidents. So these efforts to try to stop people through deterrence from driving while intoxicated weren't really working. What they did find, though, was a single policy was having a marked impact on the number of the number of motor vehicle fatalities in the United States, and that was mandatory seatbelt laws. Right. Seatbelt laws are not primary prevention. A seatbelt will not prevent someone who is intoxicated from choosing to get behind the wheel. But if they do, and they get into an accident, it will reduce their risk of death. It will reduce the risk of death in people who are in their sphere of influence on the road. And that's, I think, a really important example to keep in mind. So if we think about this, all driving is inherently dangerous, right? There are 36,000 deaths and 2.5 million injuries from motor vehicle accidents in 2019. Many safety factors like weather, road maintenance, other drivers on the road are absolutely out of your control. When you drive, this is something that I actually learned or first started thinking about listening to a podcast about the Hindenburg, the giant blimp that exploded. And the person who was interviewing an expert said, weren't people deeply uncomfortable sipping tea next to a massive balloon of flammable gas? Was that not terrifying? And his response was, well, we sit 18 inches away from an active combustion engine every time we drive to work. We've kind of normalized to that risk, right? Further, a bunch of us still do it anyway, even when we don't need to. And so while we are choosing for one reason or another, for necessity or for recreation, to take on this inherently dangerous activity, seatbelts are harm reduction and death prevention while taking on that risk. So basic assumption at the bottom of this purple book that we put together to walk you through today is people use drugs. As a public health expert, we have very long-standing relationships as a species. Human papillomavirus is one, and mind-altering drugs is another one. This is something that our species has interacted with for as long as we've been writing things down. In 2019, and this is based on SAMHSA's National Survey on Drug Use and Health, it's estimated that more than 50 million people in the United States used an illegal drug at least once. Excuse me, about 16 million people used a prescription drug without a prescription. About 5 million people used cocaine. About 1 million people used heroin or some other illicit opioid. And nearly 60% of all American adults have used an illicit drug at least once in their lives. I throw these facts out not to deter anyone from having hope that we're able to curb the overdose rates. I really, really think that we have the tools available to do so, but simply that primary prevention is not going to work for everyone. We need to have reasonable secondary and tertiary prevention strategies in mind. So one way to think about, in addition to thinking through tertiary and secondary prevention, I know those can be kind of abstract concepts. One way that I and a lot of my colleagues, both in and beyond the CDC, have found really helpful for thinking about, okay, what does secondary and tertiary prevention for overdose look like, is to think through a cascade of care. The cascade of care, to the best of my knowledge, was a concept developed for thinking about getting people living with HIV connected with care. So first of all, there's people who are out there, and then there's people, of all the people living with HIV, the ones who are diagnosed, and then the ones who are diagnosed, those who are linked with care and retained in care and on treatment and virally suppressed and so on and so forth. And a lot of the goals that we have set nationally or globally for getting people into HIV care thinks about that cascade, that we're constantly trying to move people through it. It's never going to be perfect, but we want it to be as flat as possible, right? To have as many people who are experiencing this controlled, treated, and suppressed. Right. For opioid use disorder, we know that unfortunately that curve is a lot steeper. Many people who are in need of treatment are not able to access treatment. But I'm not here to talk about treatment for opioid use disorder per se. I'm here to talk about how we can use this cascade of care to think about making a difference in terms of someone's overdose risk. So if we think about preventing, secondary and tertiary OD prevention is what we're thinking about. So we're not necessarily talking about preventing people from using drugs. We're saying if they're going to use drugs, how do we keep them from overdosing fatally? Recognizing one's own overdose risk, I think that's really important. That comes through education, it comes through empowerment, through support, because the person who is most capable of preventing an overdose is the person who is at risk of overdose. Engaging in services, that's harm reduction services, risk reduction services. We're going to be talking about syringe service programs, Naloxone, things of that nature. So just being able to go out and access tools. Learning to use those overdose prevention tools. There are lots of different strategies. Those strategies might change across different classes of substances. So really increasing education and making sure people could use them. Incorporating those tools into your regular strategies and practice. I know I, as a kid, went through lots of training with my mom to make sure that it was just embedded in my brain that I put my seatbelt on the second I got into a car, no matter what else was happening, no matter what I was distracted by. That's what we're thinking about, right? So just making this part of the ordinary, banal background noise, like it always happens, that we're taking these overdose prevention strategies while we choose to use drugs. For treatment outcomes, we should be thinking about person-oriented goals for drug use and harm reduction. So many people who engage with harm reduction services have goals that do not include abstinence, but are very much centered around risk reduction, such as changing their route of administration, changing the frequency of their use, changing their relationship with substances. So how can we support people to reduce risk according to their own goals? And then finally, integrating all of this into strategies for health and social services, not so that we like to say every door is the right door, but that every door has the tools and the knowledge and the capacities behind it to help people achieve these outcomes. So this is the purple book. That's our sort of pet name for this document. It's called Evidence-Based Strategies for Preventing Opioid Overdose, What's Working in the United States. This was intended to be a tool for community leaders and advocates, people who are interested in these issues, may have some sort of research or public health background, but might not specialize in this area, or people who are simply first responders, other types of community leaders who want to educate themselves about the research that's out there, what works, why we know it works, and how to go about doing it if that's what you want to do in your communities. This was based on more than 12 months of research into the scientific literature, multiple rounds of consultation and expert review. As an academic, I produce peer-reviewed publications a lot, and I like to joke that this is the most peer-reviewed thing that I have ever been able to have my hands on, because so many brains and so many perspectives contributed to it. And importantly, the current version was released in September 2018. So we have 3.5 years of research in between when this was published and where we are right now. And I'll be hinting a little bit about what we have done in that time since then. So here's what made it into the purple book. We had clear criteria. So one, there had to be a meta-analysis or systematic reviews, which basically means taking lots of individual studies and pooling their findings together, that shows that this strategy is effective at reducing overdose or factors that we know increase overdose risk. Or there had to be evidence from a scientifically rigorous experimental study, which is not possible or ethically possible in all cases, such as a randomized control trial that demonstrates the strategy's effectiveness in reducing overdose and or factors that increase overdose risk. Alternatively, there could be multiple observational studies from US settings to indicate the strategy's ability to reduce overdose or mitigate and reduce factors that increase overdose risk. So these are all high standards of evidence. And there's more than one because, like I said, the classic blinded trial is not ethical in some situations, right? We can't deny certain people treatment that we know works in order to come up with a new study, or we couldn't do a randomized control trial for naloxone. That wouldn't actually be ethical to deny people naloxone for the sake of a research study. So that's why we broadened it. The criteria that they all had to have, though, is that they all must have been successfully implemented in at least one US jurisdiction by the time we completed writing, and that was August 2017. All right, so these are the 10 strategies that made the cut. I will not be talking about all of these today. I'm going to be highlighting some of the highest impact ones. Medication-assisted treatment, or medications for opioid use disorder with opioid agonist medications. Those opioid agonist medications in criminal justice settings and upon release. Initiating buprenorphine-based MAT in emergency departments. 911 Good Sam laws, targeted naloxone distribution, and syringe service programs are the ones that are coming up today. All right, so let's talk about medication-assisted treatment with opioid agonist medications. So nowadays, we tend to call this medications for opioid use disorder, but MOUD, MAT, it's all the same thing. I want to point out that SAMHSA has a great document, a treatment improvement protocol number 63 called Medications for Opioid Use Disorder, that does a deep dive into all of these different medications and some of the research that I'll be talking about. So if you want to learn more, that's a really great place to start. There have been 3 medications approved by the FDA to treat opioid use disorder. Those are methadone, which is an opioid receptor agonist, which means it activates opioid receptors just as any other opioid does. The second is buprenorphine, a very, very long word that I always get tripped up on in spell check whenever I'm writing about it. You may know it by the name Suboxone or Subutex. Those are some of the brand names that it's sold under and what it's often referred to. This is a partial opioid agonist receptor, opioid receptor agonist, so it partially activates the opioid receptors like any other opioid does. And Naltrexone, which is an opioid receptor antagonist. It blocks opioid receptors. In terms of the actual facts of pharmacology, this is not entirely true, but by analogy, we could say that naltrexone is sort of like long-acting naloxone, that it blocks receptors for a long period of time. So the reason why we specifically suggest or specifically endorse treatment with opioid agonist as an overdose prevention strategy is because naltrexone, more and more research is coming out indicating that it might be associated with increased overdose risk, or in some cases we have evidence that it is associated with increased overdose risk. So I want to be very, very clear. If someone chooses naltrexone for their own pathway to recovery, they should have access to that tool. But we do know that if we are really trying to get the most bang for our buck and really help the most people come home at the end of the day, ensuring full access to the agonist medications is going to be really key. So I want to draw your attention here. This is the warnings in the FDA literature for naltrexone, and it notes that there is a risk of opioid overdose at the end of a dosing interval or missing a dose. So, and I actually know people whom this has happened to that were on naltrexone, were really happy on it. They were doing the 30-day injections. They missed an injection, relapsed, and because their tolerance was really low, overdosed. Fortunately survived that overdose, but it is a documented risk. At the same time, there is this new study that came out very, very recently. There is a trial that is known as the XBOT trial that was a head-to-head trial of naltrexone and buprenorphine. It was published in 2018, and it found that while people stayed on their treatment, the risk of overdose between those who were on buprenorphine and those who were on naltrexone was even. And that was a really major finding that suggested that naltrexone could have the same overdose protection potential as buprenorphine while people remained in treatment. There has, however, been a review of that study, and it turns out that there was quite a lot of overdose events in the original data that was missed. And so the data that was published in the original 2018 study are actually inaccurate. The original authors have published a commentary acknowledging as much. So the original XBOT trial found no difference in risk, but the reanalysis found quote unquote missing overdose events in the study data that just weren't captured by the statistical analysis. And they conclude that the hazard of overdose for patients on naltrexone is 2.5 times higher than the hazard for patients who are on buprenorphine while they are on treatment. All right, so why medications for opioid use disorder work? So MOUD, or medications for opioid use disorder, or MAT, all the same thing, are a proven pharmacological treatment. Methadone and buprenorphine activate opioid receptors in the brain. It prevents painful opioid withdrawal symptoms, which is a major psychological barrier to recovery for a lot of people, without necessarily causing euphoria, helping people gain control, change their relationship with opioid use, and start building and leading normal lives. Treatment of opioid use disorder with methadone has been shown to protect patients against fatal overdose and other causes of mortality. So it protects against death on multiple fronts. And also buprenorphine has been shown to protect against fatal overdose and other causes of mortality while a patient remains in treatment with MOUD. So both really exciting things. Important to note, medically supervised withdrawal or detoxification does not in itself constitute evidence-based treatment, even if one of these two medications, methadone or buprenorphine, is used as a slow taper to assist someone in detoxing. In fact, doing that without following up with ongoing medication for opioid use disorder, we have a growing evidence that that is increasing someone's risk of opioid overdose. The reason why is because you have lowered tolerance by stepping them down. And then if they relapse, which is completely normal, their tolerance is different. So essentially someone who is even trying to be very cautious, using less than they normally do, might still use too much because it's hard to know how much your tolerance has dropped. All right, there are challenges to accessing MOUD. In particular, we know that the average person in the United States lives 22.7 miles away from a healthcare facility that provides at least one of the 3 medications for opioid use disorder and accepts Medicaid. We know that in non-coastal states with lower population density, the average distance to such a facility often exceeds 50 miles. And if you are someone engaged in daily dosing in methadone, it's understandable how that can be an enormous barrier to care. In 2017, only 56% of rural counties had at least one buprenorphine prescriber practicing within county limits. That had grown to only 63% by 2020. And residents of more than half of small, remote, and rural areas have no local access to buprenorphine for opioid use disorder at all. If you're interested in learning more about the sort of lived experience of these challenges, I cannot recommend enough the book RX Appalachia, by Leslie Marie Boer, a wonderful medical anthropologist who has been working with women, pregnant women, women with children, and women just trying to live their lives in rural Kentucky, moving through the drug court system, moving through the treatment system. It's deeply eye-opening, and I highly, highly recommend it for those who are really wanting to understand the nuances of these challenges. All right, MAT in criminal justice settings and upon release. So this is a really, really exciting strategy for me. Why would we want to do this? Well, first of all, providing MOUD in jails and prisons not only brings healthcare and correctional facilities up to meet current medical standards for the treatment of this medical disorder, it also improves the likelihood that incarcerated people will engage in care in the future, lowers the likelihood of relapse, problem opioid use, and risky opioid use after release from incarceration. This strategy works best when MOUD is uninterrupted, or MAT is uninterrupted when initiating or being released from incarceration. We have studies that show that even if someone is on methadone when they become incarcerated and then is reconnected with methadone after they leave incarceration, going through withdrawal during incarceration dramatically decreases their motivation and their willingness to engage in care when they get out, which is a huge, huge loss for them and for public health generally. This works best when these medications can be initiated in criminal justice settings. So if someone comes in and is on medication, not only can they continue it, but someone coming in who would be benefited by that medication who's not receiving it can actually start that regimen while they're there. When all FDA approved medications are available to patients, that's very, very important. Patient preference plays an enormous role in treatment success, but also we know that the overdose protection factors of medications are not equal, and that individuals receive a warm handoff to providers who are able to continue their care upon release. So to understand what the risk is and the major impact that this type of service can have in either community supervision or incarceration settings, I want to show you a really, really powerful study that was done in my home state of North Carolina, where I am right now, by some wonderful folks in our state department of public health. So this study included 229,000 formerly incarcerated people released from prisons in North Carolina between the year 2000 and the year 2015. So very robust, large study. They found that compared to the general population, formerly incarcerated North Carolinians were 8.3 times more likely to overdose in the first year after their release from incarceration, were 40 times more likely to overdose in the first 2 weeks after release, and were 74 times more likely to overdose on heroin specifically in the first 2 weeks after release. Right? So this is why the continuation of care is so important. The greatest risk that someone has of death is immediately after release in those first few weeks. And that is a time in which we cannot play around with motivations, with barriers. Like, we need to make this the smoothest pathway for people to stay in care if we want them to continue to come home at the end of the day. So there is really, really good news, though. We know that this works extremely well to reduce overdose. This was a very exciting study that was done in Rhode Island, where they chose to make all 3 medications for opioid use disorder available to every single person in the incarceration system in Rhode Island. So this was a study of all unintentional overdoses before and after offering that low barrier care. So this includes minimum security, maximum security, jail, women's facilities. In Rhode Island, that was easier to implement because all of those facilities are on the same campus because it's Rhode Island. But it's a great opportunity to see the statewide impacts of this kind of implementation. So after they began initiating low barrier MAT to anyone incarcerated, and recently incarcerated here is defined as release within 12 months of death. There we go. They found a 60.5% reduction in overdose mortality among the recently incarcerated, so those within 12 months of release. And they also found, and I think that this is they knocked it out of the park, 12.3% reduction in overdose mortality among all state residents. So their statewide overdose mortality went down by double-digit percentages when no other policy changed in the state, which is pretty remarkable. So lots of places are already doing this. Rhode Island was a major leader in implementing this statewide. Vermont began piloting MAT care with methadone and buprenorphine in its jails in 2014. It's also worth noting that Rikers has been offering MAT with agonist medications to inmates since 1987. Today, the facility continues to provide both methadone and buprenorphine. It's really exciting stuff. There are some wonderful, wonderful healthcare providers in New York City who have been facilitating, operating, managing, and serving patients in that program for a long time. There's a lot of expertise to tap into who have PowerPoints in their briefcase and they're ready to go. So definitely reach out to folks for technical assistance if you want to get this going in your local jails. All right. Okay. Now for something a little different, initiating buprenorphine-based MAT in emergency departments. So the regulations around buprenorphine specifically allow this medication to be dispensed from an ordinary pharmacy, a hospital pharmacy, your corner pharmacy in your neighborhood. And initiating buprenorphine-based MAT in EDs basically means if someone comes into the ER, or the emergency department, the ED as we call it, and they have opioid use disorder, whether it's post-overdose or for a totally different reason, diagnosing them with opioid use disorder and starting them on buprenorphine that day, possibly even in the ER before they go home, and then connecting them with care is a really solid evidence-based intervention. So Yale University Hospital was the first institution to start initiating this. They have done a ton of studies on it, found really, really good outcomes, found that folks who started were twice as likely to be engaged in treatment 30 days after discharge compared to those who were referred to community care with no bridging medication. And Boston Medical Center runs the Faster Paths to Treatment program, which is a really, really excellent way to implement this in a low barrier way. So patients are immediately stabilized on buprenorphine or connected to a methadone program and then actively transitioned to primary care or other long-term care provider. So the goal is get them on medication right now if they want medication, and then tomorrow or the next day, we're going to deal with transferring them out to a place that can manage this long-term. There's lots of other opportunities, though, that I want to highlight besides emergency departments that are really, really effective locations for connecting people with care and with buprenorphine and in this faster paths, like bridge treatment sort of way. One is primary care settings, inpatient hospitalizations, syringe service programs, and there's actually now numerous syringe service programs who are starting their participants on buprenorphine at their site, at their brick and mortar, on their van, walking them to Walgreens straight from there to get them started, prenatal and postpartum care, outpatient mental health and behavioral health, and then, of course, all healthcare settings during incarceration and community supervision. All right, briefly, I'm going to talk about 911 Good Samaritan laws. I think this is a topic that most people are probably familiar with, but it bears repeating some of the science behind it. It's really interesting. So, excuse me. So we know that any risk that anyone on scene of an overdose reduces the likelihood that 911 will be called. We have studies on this. This is what people repeatedly tell us, and it just makes common sense. Everyone is interested in saving a life, but the choice between saving a life right now, knowing that they might not survive, knowing that you have a warrant out, or you're on probation, or you have years on your head, is a profoundly unfair choice that people have to make. So the goal of Good Samaritan laws is to eliminate that choice, the fact that they have to make that choice in the moment of emergency, right? We also have really good studies that 911 Good Samaritan laws, knowledge of this among people who use drugs and among people who are in a position to witness an overdose, that knowledge increases the likelihood that they will call 911. For those of you who might not be familiar with the term, the super brief definition of a 911 Good Samaritan law is that there is limited immunity from criminal consequences, usually for drug possession or paraphernalia possession, limited immunity, right, from those laws if you call 911 to report an overdose, or if you're someone who has experienced that overdose. Every state law is a little bit different, but that's the general gist of it. We do have evidence about what makes a really strong Good Samaritan law. We know that when immunity is extended to all people on the scene and not just the overdose victim or the person who called 911, the law works better. We know that when bystanders are protected from parole violations and warrant searches, in addition to any immunity that's afforded by the law already, the laws work better. We know that when police officers and other first responders are well informed about the specific provisions of their state's 911 Good Samaritan law and other state and local regulations, it works much better. And I emphasize that because the laws do vary. Some states provide immunity from charge. Some states provide immunity from arrest. Some states only allow the law to act as a positive defense or an affirmative defense. So really, really grounding officers and giving them the training that they need to professionally and effectively implement that law on the scene of an overdose is necessary. And finally, when people who use drugs are well informed about the law and have reason to trust that those protections will consistently be afforded to them when they call 911. I think that's an important thing to emphasize, that trust around the Good Samaritan law is something to be earned in a lot of communities. It takes a little work to do that, but it is absolutely doable. All right. So this is actually a study that we did through the overdose response strategy several years ago. We had the privilege of surveying almost 3,000 patrol officers across 20 states about their knowledge and experience, a knowledge of the Good Sam law and experience responding to overdose. And I wanted to point this out, the very top line here. So among those who had responded to an overdose in the past 6 months, and that is more than 1,900 or almost 2,000 of the responding officers, 37% reported administering naloxone at the scene of an overdose, which is great. And 36%, so more than a third, reported making an arrest at the scene of an overdose. There's many legitimate reasons why an officer would need to make an arrest at the scene of an overdose. If there is violence on scene, if there are major crimes unrelated to the overdose on scene, there are times when that is necessary. However, if we are thinking about really trying to maximize the efficacy of Good Samaritan laws, people who are likely to call 911 are aware of the fact that they are likely to get arrested if that is what's happening on the ground, regardless of the actual statute in every single state and what it contains. So I think finding ways to really, really understand why those arrests are happening in our states and figure out how to mitigate them is going to strengthen the Good Sam law and reduce fatal overdose. All right. Targeted naloxone distribution. So naloxone is an oldie but goodie, right? It is an opioid antagonist. It reverses opioid overdose. Almost every state now has a standing order for naloxone, so the public can access it. People who are the most in need of naloxone are people who are likely to witness an overdose. Those are people who are more often than not folks who use drugs or friends and family of folks who use drugs, right? What I want to mention here is that there was recently a modeling study that was done, where the need of naloxone was modeled across the United States. So the need of how many kits need to be given out, how many naloxone kits to people through harm reduction programs, through pharmacy, over-the-counter sales or distribution, in order to actually achieve a meaningful reduction in death. So the outcomes that they looked at were things like, is it likely that someone observing an overdose will have naloxone on them? And how many deaths are actively being averted by getting the naloxone in the places where it needs to be. The implications of the study were kind of jarring. We know that naloxone reverses overdose because literally that is chemically what it does. So having it available at every overdose is our ideal goal. And they said, our results highlight that current naloxone access pathways in most US states are underdeveloped. Additionally, we estimate that community-based programs and pharmacy-initiated models provide the greatest effect per kit distributed compared with prescription-based programs. And they provide state-based targets of distribution to guide policymakers. I want to they gave actually a couple of examples in some of their press releases about this. All of the state modeling is available at this website, naloxoneneededtosave.org. But here's something that the researchers said in the press release about the study. They said, for example, in South Carolina, in 2017, South Carolina had more prescription opioid overdoses, relied heavily upon prescribers and pharmacies for naloxone access, and lacked a community-based naloxone distribution program. It would need over 35,000 kits distributed per year through those pharmacies in order to achieve the target benchmark of having naloxone available at 80% of witnessed overdoses. On the other hand, Illinois, a large state with high numbers of heroin and fentanyl overdoses, relied less upon prescribers and pharmacies to distribute naloxone and more upon one centralized community-based program hub. Illinois would need 162,306 naloxone kits per year to meet the same goal. I find that really, really staggering. Naloxone can be cheap. Naloxone is something that we can, many people have organized special deals, special buyers clubs. So finding ways to get this much naloxone out there is going to take some clever creativity, but that is an indication of the amount of naloxone we need out there. Every kit leaving the door is helpful. So if you feel like your community can't meet these benchmarks, that is not a reason to stop the naloxone program that you're doing. Keep doing your naloxone program, but the amount that's needed is really, really high. And I think we've been underestimating what that is for a while. All right. Part of the reason why I mention this now is because many syringe service programs in the United States operate through what is called the Naloxone Buyers Club. They collectively pool resources to get special prices from naloxone manufacturers, but those are single supply chains where if anything goes wrong in that supply chain, they can be left without these essential services. And this is what happened earlier in the year. There was a naloxone shortage because the company that was making the specific formulation that was included in that special agreement had a manufacturing issue, like a doodad fell off a gewgaw. It was an ordinary run-of-the-mill fabrication maintenance issue that they had to manage, but it really left harm reduction coalitions scrambling. So while we are getting naloxone out into the community, thinking about ways to stockpiling it, thinking about ways to share naloxone across agencies is going to be really important. All right. Syringe service programs. I called naloxone an oldie but a goodie, but this is really the oldiest and the goodiest of all of them. So I believe we all know what syringe service programs are, but in brief, we tend to, in layman's term, call them needle exchanges or syringe exchanges. Public health agencies prefer syringe services programs because the term syringe makes us recognize, yes, these places, and services indicates that there's actually a massive variety of services that these organizations offer beyond syringe access and syringe disposal, right? If we're just looking at the syringe part, though, we know studies have found that people who use SSP services or syringe service program services are many times more likely to enter treatment than those who do not. I think that this is really, really important. There are many pathways to treatment, and you heard me say earlier in this talk that every door is the right door. Every door should be the right door. Every door should lead to a path to recovery. Syringe service programs are the 6-lane boulevard. It is such a heavily trafficked pathway to treatment. I can't emphasize that enough. So things that might limit access to these services or discourage people from seeking these services are equally limiting people's access to one of the most heavily trafficked pathways into treatment and recovery. SSPs are particularly good at attracting recently incarcerated individuals who we know are at astronomically high risk of overdose post-release, and ensuring that those individuals have access to naloxone, have access to medications for opioid use disorder, to HIV care, and other essential services. It's also worth mentioning that all of these fantastic benefits of syringe service programs are greatly reduced by programs that require a one-for-one exchange. So the opposite of one-for-one exchange is what we call need-based distribution of supplies. That essentially means within reason, giving people the amount of supplies that they need to get them through until the next time that they're able to come back for services. So an example, Scott County, Indiana, and we've actually had several other examples since then, but in 2011 to 2015, there was an HIV outbreak driven by an increase in drug injection in an environment where syringe access programs were shut down and paraphernalia severely criminalized. People resorted to syringe use and syringe sharing. More than 135 new cases in a community of fewer than 4,200 people is a pretty phenomenal outbreak. We also seen similar things in recent years in Massachusetts and West Virginia. So it only takes a small amount of time after services become unavailable for really massive public health emergencies to emerge very, very quickly. I also want to show you a photograph, and this was shared with me by a really wonderful harm reduction advocate named Claire Zagorski, who works with the Texas Naloxone initiative. This is a photograph that she shared of a syringe that was being used by an individual that she found during outreach. I believe this comes from Claire, that was not able to access syringe service programs. And I share this because if there are individuals in your community who I think not unreasonably are concerned that access to syringe services or access to drug use paraphernalia might increase or encourage substance use, I would like you to keep this in mind. Right? This is what people are turning to if they cannot access clean syringes. I think this is really, really stunning. We have great science that tells us that SSPs do not increase syringe litter. They do not increase crime. They do not increase substance use in the areas where they are implemented. Every community is a little different, but we're not seeing that happen. When those services are not available, though, people use drugs, and denying folks access to these really, really essential tools to stay safe just means that they're going to resort to really, really unsafe choices. All right. As I mentioned before, SSPs heavily trafficked pathways to care. So people who use SSP services, and this has been established in the peer-reviewed literature, are 1.4 to 3.2 times more likely to enter detox compared to those who don't. They're about 1.7 times more likely to enter treatment for a substance use disorder. They're about 5 times more likely to enter treatment and 3.35 times more likely to cease substance use altogether compared to those who don't. That's a Baltimore study versus a Seattle study. They have access to safer injection equipment. They have access to safer smoking equipment in case they want to quit or don't want to start injecting. Right? Those are people that we also want to make sure have this great access to medications, to HIV testing, to treatment. And finally, they have access to naloxone and overdose prevention education. These are all things that reduce opioid overdose risk. So SSPs are our heavy hitter time and time again, not only because they themselves increase the uptake of these other services, but they provide these other services as well that we know reduce overdose. And this is the new exciting thing. They make sure that their participants have access to other overdose prevention tools like drug checking and fentanyl test strips. All right, so this is the last thing that I really want to talk about today. This is not something that is included in the CDC evidence-based recommendations because this was really developed, and a lot of the science behind it that was developed, at least in the United States, after the publication of the book. But I want to talk to you a little bit about what's happening around fentanyl test strips, around a strategy that we call drug checking. I think that this is an extremely promising strategy. I think that we are seeing overwhelming evidence that this is a really, really big ticket item in overdose prevention. I'm really excited about it, and I'm excited to see it expand. So my home state of North Carolina has been very heavily involved in building the science behind this. So fentanyl test strips, as you saw in the picture on the last slide, is like a little, it looks like a pregnancy test. It's a little litmus paper that you soak up a fluid into, and it gives you a, 2 lines. It's the opposite of a pregnancy test. So it's 2 lines no, one line yes. Is fentanyl present in this particular substance? So the first major study about whether or not access to and use of those strips could have an impact on overdose risk was conducted at the North Carolina Survivors Union, a large drug user union and syringe service program in North Carolina. So what they found, the syringe service program was already distributing fentanyl test strips. So this was a community-driven intervention. Researchers just came in afterwards to study how it was working. They did a survey of 125 people who inject drugs. And I will note that not all participants in the syringe program actually inject. Many come from many other reasons. But of those who inject, 125 and who use fentanyl test strips were surveyed. 81% of those surveys used the strips before they consumed their drugs, which is sort of what we want, right? It's like putting your seatbelt on before you get in the car crash, right? Putting it on after the car crash, you're like, that's great, but it didn't actually prevent anything in the moment. 61% of people had at least one positive test result over the study period. So they tested the drugs that they suspected might have fentanyl in it and found that they were correct. I think this is particularly important in North Carolina in 2018, when we were not drowning in fentanyl. You could actually go out and specifically ask to buy heroin and successfully buy heroin, which is not something that people in a lot of parts of the country have been able to do for a while. So here's the exciting part. People who had a positive result and found out, oh, I thought this had fentanyl in it, and now I am sure it had fentanyl in it, had 5 times the odds of adopting at least one of these known risk reduction overdose prevention behaviors. They used less of the drug than they originally intended. They used more slowly, so they could pace themselves. They took a test hit to sort of see how they would be affected by the drug that they were now unfamiliar with. They chose to sniff instead of inject, which for a lot of opioids can reduce your risk of overdose. And this result has been actually generated in other studies. So it's not just a unique North Carolina thing. We've seen it in a lot of other places. There was a study of 93 young adults in Rhode Island who inject either opioids or cocaine. 68% who got a positive test, that's the little plus sign for these, 68% of those who got a positive test used slower, used less, or chose not to use those drugs at all. A study in Baltimore of 103 self-identified female sex workers in Baltimore who use opioids, 69% who received a positive test used a buddy system, which is great because if you have lost consciousness and stopped breathing, you can't Narcan yourself, right? They used slower or they used less. And another outcome that they did not expect at all but identified is that there were significant reductions in injection frequency and daily opioid use among those who were using the test strips and getting positive results. There was a study in British Columbia of 1,141 unique drug checking procedures. So drug checking can mean either fentanyl test strips or a more advanced technology to help people understand what contents are in their drugs. By unique drug checking procedures, we mean individuals coming to the counter to talk to a staff person to use these technologies. So it's not 1,000 individual people, but 1,000 individual instances. 48% of those who got a positive test used less or didn't use at all. A study in Delaware, 69% who had a positive result used a buddy system, used slower or used less. That is not a typo. There are actually 2 studies with 103 people who found that 69% of folks use these risk reduction strategies. So really, really robust evidence that this is prompting people to be safer and reduce their overdose risk at the time that they use drugs. There's other devices that are being used by an increasing number of harm reduction agencies, syringe service programs, and other types of healthcare service providers across the United States. On the one hand, these things are really effective. On the other hand, they're very cool. They're very cool to see in use. And if you have an opportunity to visit or see one of these in use, I highly recommend that you do it. I'm sure all of my toxicology friends are like, yes, 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 it's a Fourier transform. I think it's extremely cool. But the one on the left that you see, the device that kind of looks like a cross between a receipt printer and a microscope, that's a Fourier transform infrared or FTIR spectroscopy device. That is the thing that most people are using. And based on conversations happening in the harm reduction and drug checking community internationally, that's sort of emerging as probably the best tool available currently. On the right, other people have used devices such as a high pressure mass spectrometer. This does trace amounts. It's not super dissimilar from the sort of things that are used at TSA when they wipe down your bag and wipe their gloves and put this slit into the machine and it reads out that you're all clear. It's a very similar type of technology. And what it's able to do is show more information and to create an opportunity for people to understand what's in the drug market, make more informed choices. It's really exciting stuff. This is a video that was produced by a wonderful colleague of mine, Nab Dasgupta, at the University of North Carolina about drug checking that's happening here. I'm going to play it for you. It's a little bit dramatic, but that's okay because this is exciting. We can be a little bit dramatic. There we go.
During COVID, street drugs in North Carolina have become unpredictable and treacherous, causing historically high overdose deaths. But we don't know what's in them until it's too late. So the North Carolina Survivors Union in Greensboro provides prevention and rescue services to anyone for free. We want people to make better choices about what they put in their bodies. For years, we've used disposable test strips to detect the potent opioid fentanyl, but fentanyl isn't everything. To help, the photographer Nan Golden gave us a gift. This spectrometer uses infrared light to figure out what is in street drugs. In 10 minutes, the return results help people make informed choices about what to avoid. It provides validation for bad experiences and opens the door for rational conversations. We detect harmful cuts and fillers in real time, preventing medical emergencies. Complex samples are sent to our lab on the UNC campus in Chapel Hill. High-precision machines use heat and pressure to uncover additional details. Inspired by COVID tests, we invented a new swab technique to harvest residue from discarded baggies. We are expanding this anonymous service to the rest of our state. When addiction treatment is still in short supply, we must consider safe supply. Otherwise, we will never bend the curve on overdose deaths. After 2 decades of unrelenting increase, it's time for new solutions.
Oops. I just had to plug in my computer so it didn't die and it turned off my screen. I'll bring us back there in just one second. Okay. Thanks for your patience while I deal with, I'm so lucky to have these fancy new monitors at work and they don't always do what I anticipated they were going to do. Okay.
What a great video though, Dr. Carroll.
Yeah, they did such a fantastic job. Okay. All right, is that still showing the slide, not the presenter view like it's supposed to?
Yep, you're good.
Awesome. Thank you guys for your patience as we roll with this. 2 years into COVID, still figuring out Zoom. Good at lots of other things though. Okay. So a couple last points here. So one of the reasons why these sort of drug checking services I think are terribly exciting beyond fentanyl test strips is because they're allowing people to understand and identify new cuts in their in the local drug supply and respond to them accordingly. Xylazine is something that more and more people are starting to learn about. What I have learned from my colleagues whose job very literally it is to know better than me is that xylazine is an opioid that is probably not implicated in fatality, but is definitely changing people's experience of substances and is associated, at least we believe, evidence is growing, with soft tissue injuries for a lot of very specific reasons having to do with xylazine and the ability for small injection wounds to close and heal properly. So this kind of work is helping people really understand how they need to change behavior, or possibly even providing the impetus for behavior change in a larger way, like in a pathway towards recovery or to someone's personal goal around their substance use. And then in addition to just as a basic overdose prevention strategy, there's a lot more really exciting things coming out of drug checking. Part of the reason why syringe service programs are such a heavily trafficked pathway to treatment is because they provide services that people want. And once people show up to make use of those services, to reduce their own risk, to take better care of themselves, they enter into a caring, non-judgmental environment where there's space to have discussions about substance use, where there's space to have an opportunity to think and reflect on what their goals are for themselves. And that becomes a very safe, like that's the person you're gonna call, right? At 2 in the morning, at 3 in the morning, at 8 in the morning, whenever you're like, I need something to happen for myself, you're going to go to that person that you know cares about you deeply. And those are really, really strong relationships. So providing things that people want to keep themselves safe is a key element in making this work. So this is actually an article that I published very recently with some really next level harm reduction advocates. And we learned that actually in a drug checking program that they stood up at their mobile, or both brick and mortar and mobile syringe exchange was really impactful in other ways. So this is an excerpt from that article. So SSP staff described encounters perceived to be proof of concept that drug checking offers an effective pathway to treatment, just like syringe services, naloxone services. An SSP manager spoke of a participant who had fallen out of care at the Health Care for the Homeless program after testing positive for HIV. Outreach staff found her upset about her HIV status and on a tear, binging cocaine. She rejected the staff's attempts to engage her until she was offering drug checking services. And this is a direct quote from the manager. Finds the woman on the street and she's like, you mean you're going to tell me you're going to test my shit? And I'm like, yeah. So she went back to the van, did drug checking. They started talking. That actually led to her talking to the doctor, sitting down with the doc, working on her HIV care. Like, I could not make up a more perfect story. Other stories recounted of proof of drug checking's impact as an engagement tool included housed and employed persons, so folks who are least likely to walk into the door of a syringe exchange, who use drugs intermittently, like on weekends, for example, seeking drug checking for stimulant and opioid drugs that they plan to use. One occasional user was surprised to learn that his heroin was actually fentanyl, and the client subsequently developed a prevention strategy with staff that involves changing his intended route of administration. So lots and lots of potential here. The evidence is growing, the number of people implementing it are growing, and I think it's very exciting as well. It's something that I'm very excited to talk to you about, either in the Q&A or after this is done. So that is the end of my spiel. Thank you for bearing with me while I had technical difficulties. I really appreciate y'all's time. I know we covered a lot of ground, but I'm super eager to take questions.
Thank you so much, Dr. Carroll. We have lots of questions that are coming in through the Q&A. If you have questions, please add them there and we'll get through as many as we can. If we don't have enough time, we will get back to everyone and even send out some Q&A to all the attendees of today's event. And I know that our team has jumped in here, but we will make a recording available of our webinar along with our presenters' slides. We will also send out the Purple Book from the CDC, which for me is required reading if you're on staff at Addiction Policy Forum. And I think all of us in the field, it really is an important resource. So with that, we're going to jump right into questions. One question I had, which sort of gets to the dovetails with our first question here from Jerry. The Purple Book came out in 2018. Would all the studies and the evidence that you laid out on fentanyl test strips, would that be enough evidence to include that in, let's say, an update of that book today? Do we have evidence to sort of put forth that fentanyl test strips are an evidence-based strategy for reducing opioid overdoses?
So what I would say to that is that speaking only for myself, yes. I personally am very confident that it meets the criteria that we set for the original Purple Book. That said, reasonable people, reasonable educated people disagree. And so there is a very important and very thorough vetting process at the CDC. So whether or not this ends up being in like Purple Book Volume 2 is an open question, and it's still under discussion. And so I can't make any predictions about that, because in order to do so, it requires brains other than mine be in the room and be evaluating the evidence. Speaking for myself personally, I am confident that it does. Mm-hmm.
And we do fund it. So there you go. It is.
That is a good point. Yes.
We do fund it at this point. So fingers, we shall see.
Yeah, April 7th, 2021, as I believe it was, help me remember, Michelle, it was both the CDC and SAMHSA allowed grant money from them to be used to purchase fentanyl test strips. Yeah. Thanks. That was very exciting when that happened.
That's fantastic. Very important update. And thank you for all the info about all drug checking and some of the advancements. It's so important for us to keep our patient population safe. So another question from Anita about, are there studies involving probation, community supervision, and what can be done to reduce overdose within individuals active on probation or community release?
Yes, we do have some studies about that. I'm not going to be able to recall them off the top of my head, but we have a lot of studies that have looked at the continuation of care after release. Those best practices are honestly, probably I would go to your community care providers to understand those best practices, because people who are under community supervision, if anything, they are facing the exact same barriers that people not under community supervision in the community are facing, plus a little bit more. But if we want to look at it this way, they have the advantage of checking in with folks who can pull strings, who can make connections, who can do referrals, right? Their parole or probation supervisor has the capacity to be that advocate for them, and they could play a very, very key role in making sure that people have open doors to all of those accesses if they decide they want them.
Thank you. I have another question from Sarah. Are there studies looking at implementation strategies around adequately educating the general public on Good Samaritan laws in high-risk communities?
Yes. So the general public, I'm not quite sure. I do know that there have been a number of studies around the education of people who use drugs, and typically that education takes place through syringe service programs. So it's outreach workers who are trained to do this kind of engagement, trained to do this kind of counseling, and are just really stinking good at what they do, who are the ones that are doing that type of education. So yes, there are studies about that. And really it's just a matter of empowering, at least the literature that I'm aware of really just emphasizes being able to empower outreach workers to engage folks as their skill dictates and educate as their skill dictates. You know, when I was working at syringe service programs on the West Coast many moons ago, I mean, when we were doing naloxone education, there are some folks where we would sit down, we would grab the whiteboard, we're like, grab a patch of curb with me right here, we're going to talk about, and there's other folks that just like weren't available, didn't have the time, and we would like toss it in the car window as they drove away, and we're like, just give it to them in rescue breaths, you can't hurt them, go, you know. And so all of those types of interactions are helpful, and it's really the outreach workers that know their communities best who are going to be able to strategize and adapt for the people that they work with.
Yeah, that's great. Thank you. So a question from Dennis. I'm the father of an adult child who overdosed on heroin at the age of 33 after suffering from an undiagnosed and untreated trauma at the age of 5. It is my understanding that trauma is one of the primary risk factors for self-medication and overdose from opioids and other drugs. If this is the case, why is evidence-based screening and treatment of trauma not a significant part of overdose prevention strategies?
That is extremely unfair, and I'm very sorry to hear that that happened. It's unfair every single time. So my sympathies and condolences. I too have lost people that I love very, very deeply to overdose. So I think you make an excellent point. I know that there are forthcoming products from the CDC that really heavily emphasize trauma and trauma-informed care. Trauma-informed care is becoming a recognized skill set in its own right in a clinical setting. And it is something that a lot of syringe programs that I am familiar with and have worked with already do. The question as to why it's not out there in the literature, it is a bit. We have more work to do there. But I think I don't mean to talk around your question, but I think the reality is there's only so many scientists in the world and only so many people working on this, that it can be really challenging to hierarchize the priority of what is the thing that is going to help the most people survive tomorrow. And so we tend to gravitate to these really high impact things like naloxone and access to medications for opioid use disorder. It is not a completely neglected area of research. I think, in speaking for myself, I know that a lot of clinicians are starting to pick that up, and I hope that our partners, not in public health or in harm reduction, but clinicians, medical providers who themselves are public health and harm reduction advocates, can help us with that lift and get more of that work done, because you're right, it's very important.
And from to add to that, Dennis, we've really been focused on how we can identify adverse childhood experiences, and on the prevention side and understanding certain risk factors, this is really critical. A couple of things to sort of mention. We have a study that's coming out in next month with that sort of map the patient journey of individuals in recovery from substance use disorders. We found an average ACEs score, and ACEs, adverse childhood events, they can sort of come from that big Kaiser study, and we know the really significant health consequences, including substance use disorder and other sort of issues that come out of having childhood trauma. So for our patient population, we found an average ACEs score of 4, with 30% of individuals reporting an ACEs score of 6 or higher, which is really clinically significant. So it is important that we address childhood trauma specifically. The UCLA has a good screener. California does ACEs Aware. We're working with one county in Massachusetts that has a really amazing program specifically for middle school students with ACEs, usually connected to parental substance use disorder, and we can share that information with you, and that's available on our website. So I love that today, we, just because of timing, we're really focusing on strategies that really have a huge return on investment, but these efforts that go upstream to really address these significant risk factors is also a really big priority. And maybe we need a series of these webinars or some additional follow-ups, because they're all on the radar screen, and appreciate you raising the question, and I'm glad you joined us.
Yeah, and I would add, this is also, I think the point that was made is one of the central reasons why there's so much effort to just link people who are at risk with healthcare generally, and increasing, and you can use the SSP as access to primary care. You can use the low barrier buprenorphine clinic in order to get people linked with other things, or even just integrate that stuff there. And the more that people are interacting, whether they are an MD, whether they're a certified drug and alcohol counselor, whether they're a deeply experienced outreach worker with lived experience of their own, the more contact people have with these helping professions, the more equipped we are to be able to tackle those issues of trauma and the needs that people have that contribute to the risk that they face.
Thank you for that. I have another question about, are there efforts to include naloxone with AEDs and defibrillators?
Yeah. If I'm scooping somebody and taking their fire away, I apologize, but I think this was innovated in Rhode Island. At least that's where I first heard of it. I don't know if there's some other state out there that I just played dirty. I really apologize. But in Rhode Island, we called them the Nalox boxes. I think that's the term that's kind of circulating. Yeah, they're exciting. I think that putting naloxone out there, normalizing it, the same way that we normalize EpiPens and defibrillators, and just like, having that cool little barrier for providing rescue breaths from the American Heart Association on your key ring. I mean, just honestly, even just having it present and people being able to see it and know that it's there, I think can be as impactful as having it there when it needs to be used. We've known for a long time that in addition to people who use drugs, the folks who are most important to train are librarians and fast food and retail workers and security guards and folks who are just like in public spaces where people congregate and where folks might go. We know that if someone still is not quite connected, doesn't have a strong community, doesn't have someone they can call on, if someone has the potential to build those relationships but hasn't yet, we know that going to public bathrooms is an overdose prevention strategy, because if something goes wrong, they feel like they're more likely to be found. Like that's acknowledging risk and taking steps to reduce risk, even if the choice to not use at that moment is not plausible or available to them at that time. So yeah, I think I put it everywhere. If you ask me, every mailbox, every cubby, every airport bathroom, I think that would be great. I would love to see it.
That's great. We'll have to shine a spotlight on all these innovations and new ways that people are normalizing naloxone access. That would be a great thing for our community. We have a question from Lakeisha. The FTIR and HPMS, how costly are these diagnostic equipments, and can they detect all pharmaceutical agents at precise amounts or just narcotics?
Tisha is my friend. Okay, these are great questions. So they do cost a bit of money, depending on the type of arrangement you're able to make with the manufacturer. You're looking at least $30,000 to $40,000, if not more, for a single device. And they are not tough books. They are finicky. They do not like humidity. They do not like all of the dirty stuff that is in street drugs. These are things that were mostly designed to test like laboratory chemicals that are, clean and pure. So they're not perfect. What they are not able to do is tell proportion. They can give like a little bit of insight into proportion, but they're not able to be like, this is 6% fentanyl. Right? That's just not possible. The HPMS is like, I've jokingly called it the clear blue easy of drug checking. It's like literally the screen says cocaine, fentanyl in words. Those can be inaccurate sometimes. Also, if you go over to the FTIR, it has a limit of detection that might miss certain things. So even the fentanyl test strips themselves can miss carfentanil. If that happens to be, I don't think that's in very many drug markets anymore, thank goodness, but it's when it's in there, it's in such low concentrations that even it could be missed by this deeply, deeply sensitive strip. The FTIR, the output that it gives is called spectra. It is a bevy of colored lines, and it requires someone that is trained to be able to interpret it, to be able to read it. It is not foolproof. It is not the gold standard. That would be the GCMS or the LCMS, the liquid chromatography gas spectrometer, or mass spectrometer, gas chromatography mass spectrometer. Those cost, universities own those. They're impossibly expensive, but they are able to provide a lot of really interesting insight. There is, in order to discover what is in something by way of interpreting those spectra, you need essentially an electronic library of known components and known chemical elements. And so many folks that are just ordinary chem labs or tox labs will subscribe to like really big, sometimes they're privately held, sometimes it's like wiki FTIR, kind of like public labs run by, or public libraries run by universities. And a lot of people who are doing drug checking, because this is really a global movement and there's a lot of very regular, very intimate global collaboration around building up this technology for this specific use. There's a growing library of weird stuff that's out there in drugs that people can log into to make better use of those FTIR. So the learning curve is very steep and folks are going up it very, very quickly. So the information that I give you today is probably going to be obsolete in 6 months because they will have done something much, much better. But it's really, really exciting work.
That's great. We have so many questions that have come in. If we don't get to all these, we'll put a Q&A with our experts
Happily.
up on the website or something. So we'll get to as many as we can in our remaining 8 minutes with y'all. But
I'll try to do
are there any DEA rules that interfere with jails offering MAT in incarceration settings? And how do jurisdictions handle diversion?
that is above my pay grade. I know a bit about DEA rules with buprenorphine and SAMHSA rules with methadone. I don't know well enough to be able to speak there, but I know that thank goodness there are many, many experts out there who can. I believe NASTAD does technical assistance around this. And I would also, to be perfectly frank, if they don't disown me for saying this, call the folks at Rikers, call the folks in Rhode Island. Even if they are not available to sit down and provide technical assistance over the phone, they'll know where to point you to. This expertise exists out there.
One item that we have, so the former Secretary of Corrections in Pennsylvania, John Wetzel, did a webinar on sort of the 12 steps to implementing MOUD in your prison. So we can make that available and put it in our follow-up to all of our attendees today. So you can have access to that. There's some other resources and materials are there, and he does address sort of the diversion piece. There's lots of systems that have made all three forms of MOUD available and done so successfully for their individuals that they serve. So we'll send that to you all. I have a couple questions about fentanyl test strips have come through. I'm going to try to put these together for time. A little bit about it can be a little unpopular, still sort of on the can't use funding for lists for some places, unfortunately. How do we change people's minds? And then another question about if there are any law enforcement that are distributing fentanyl test strips anywhere in the country.
Yes. So the question was it about funding or changing people's mind, or both?
It's about changing people's mind, and are any police law enforcement doing this?
So, I mean, yes, the police assisted, I'm going to get it wrong, Police Assisted Addiction Recovery Initiative in Massachusetts. They are actively working with harm reductionists to distribute fentanyl test strips. So like you can get a fentanyl test strip from a detective in certain parts of Massachusetts, which is a really, really exciting sort of development. They're really great. PARI is what they're called, and the website is PAARI, if I'm not mistaken. They even have roll call training videos for law enforcement departments to talk about fentanyl test strips, how they're used, the techniques behind them, the science behind them. It's just, I mean, practical stuff that someone needs to know to kind of wrap their head around what it is and what it does. And someone in the chat, thank you. Yes, it's PARI. And so those are a really, really fabulous resource. I think a lot of the issues that we face culturally are really about the common sense that we have as a culture. So, I mean, fundamentally, I'm an anthropologist. So while I have a degree in epidemiology, I have clinical research training, like we're definitely in my corner of the sandbox here. The thing that I study from 9 to 5 is how people tell stories about themselves and about each other, because that's basically what culture is. And we tell a story that's not entirely accurate about substance use disorder. It's not based in science, it's based in metaphor, and it has to do with people's brains being hijacked or losing free will. And so, you know, I don't want to speak to anyone's experience. If you've experienced substance use disorder and you're like, yeah, that's exactly what it was like, then you're correct, and I'm inaccurately describing your experience. But when we use that as the majority or even all of our logic for thinking through what is a reasonable response to overdose and substance use, it becomes common sense to think about things like syringe access, naloxone access, fentanyl test strip access as enabling a behavior that someone cannot do, right? It's like, this is my child, he's 3, you left an entire bag of marshmallows open in front of him. What did you think was going to happen? Or like, I'm just like, it's so obvious. We know that adult brains don't work like that, and people who live with substance use disorder aren't that black and white and are actually able to make profoundly powerful decisions for themselves, even in the context of substance use. So I think it's very, very reasonable for someone who doesn't have that deep knowledge of what substance use can be like, and about how many people who use drugs who do not live with substance use disorder. The vast majority of people who use drugs do not have substance use disorder. I guess my point, it's not unreasonable to worry about that. It's not unreasonable to worry about that because our culture's common sense tells us that we should worry about that. But we have tons of science, tons of stories, tons of research, tons of testimony, individual people talking about it that tells us that that's not actually true. And I actually think that's quite exciting. I think that's very, very exciting because our common sense would, I think, encourage us to be very, very hopeless. And we have a lot of reason for hope. We just need to be able to wrap our head around the fact that our common sense is not necessarily leading us down the right path.
I appreciate that perspective, and also just kind of ending this webinar with that message of hope, because these strategies and having so much evidence behind things that we can implement today to really change the trajectory of where this is heading, of reducing overdoses, reducing overdose fatalities, that is a reason for hope. And it's something that we can all really sort of rally around and focus on in our own communities and states immediately, which we're so excited that we could highlight your work, Dr. Carroll, the amazing work that the CDC has done to put out the guidance to fund so much of this work and to help support communities address addiction from a public health framework. We're really grateful to you both for taking the time with us today. I got through like half the questions, so I'm going to consider that like a positive one with more than 40 that I think came through over short order. We really appreciate everyone taking the time today. Any sort of last thoughts for both you, Dr. Carroll and Michelle, as we wrap up?
Michelle?
Just thank you. We could do this for days. We could just have like several weeks where we would just get together for like 2 hours and talk about this. But one thing is, I think, just gratitude. So you all do so much work on the ground and you're doing it right and you're asking the right questions. And so just a profuse thank you. And we're so grateful to have you. So that's my 2 cents. I'm sure we'll talk again. And Dr. Carroll, I'll turn it back over to you.
Yeah, I would just end with, we have a fabulous group of advocates in North Carolina called they run a group called Faith in Harm Reduction. They are men and women of the clergy who have developed harm reduction oriented Sunday school adult curriculums and all kinds of stuff. And they have been an enormous support to people who are living with trauma, who are losing community members on a regular basis, who are fighting this fight either from a public health department, from a syringe program, from their own couch and living room and their family. I can't express my gratitude for them enough. And they have a sticker, a slogan, and it simply reads, people who use drugs are beloved by God. And I was raised in the church. I was raised in Texas, shout out to Harris County. But that is what motivates me. That does not have to be what motivates you. But if it does, know that you're not alone in having that motivation. I think we're entering into a really exciting space, and we do have the capacity to make sure that everyone comes home at the end of the day. We just have to keep trying. We can't give up. We have the tools. We just have to find places to use them.
So right, Dr. Carroll, thank you. I make sure everyone comes home, I think, is something we can all put. We should have more stickers with that on it too. So we will continue this. We have follow-up items coming to your inbox. If you are not registered for the webinar, please shoot us an email at info@addictionpolicy.org, and we'll make sure you receive all the materials from today. Thank you to our experts and for everyone tuning in. We had folks from all over the country. This will be the beginning of a series this year from Addiction Policy Forum to shine a light on evidence-based strategies to address addiction and to make sure that we hold up the innovations and the programs on the ground that are doing such amazing work. And until our next event, again, thank you, and we'll send follow-up materials right away.